So this is going to be esophagogastric cancers in 60 minutes or less. Now it's going to be 45 minutes or less because I thought my talk was, it wasn't where I thought it was. So what I was going to do was cover treatment of localized cancers and then go on to talk about metastatic disease. And I don't exactly know, some of you guys have heard this before, I know, because last time I gave it was January of 2012. And so it's a lot similar, but then I included some stuff about targeted agents at the end. So just by way of background, esophagus cancer, about 18,000 new cases in 2013, 15,000 deaths, actually up. I had this for 2010, and it was like 15,000 cases, so it's actually up. 15,000 deaths. It's 3 to 4 times more common in men, and as you can see, the 5-year survival is pretty crappy. If you put everybody together, it's about 15%. Even those with localized, quote-unquote, curable disease, it's still only about 35 to 40%. So gastric cancer is a little bit more common, 21,600 new cases, about 10,000 deaths. It's the third most prevalent cancer worldwide. Esophagus cancer is also way more common outside the U.S. And the global 5-year survival for gastric cancer is 7 to 14%, so not dissimilar to esophagus cancer. There are some of these people that we cure, but the vast majority we do not. And together, the two of them are responsible for about 1 million deaths worldwide. So in terms of esophageal cancer, you can either have squamous cancer or an adenocarcinoma. Squamous cell is more male predominant and African Americans greater than whites. Esophageal adenocarcinoma has the fastest rising incidence of any cancer. So we used to not see it very much at all. It used to be squames associated with smoking, drinking, things like that. Now, vast majority of what we see is adenocarcinomas. We don't see very many squamous cell cancers at all. And male predominant, although this adenocarcinoma is whites greater than African Americans, incidence increases with age. It's associated with obesity, Barrett's, those kind of things. So this is just incidence of esophageal cancer. So you can see in white males from 1985 to 2005 it's been going up. And if you look in African Americans, it's been going down. That's more the squame, and then the adenos are going up. Risk factors, so for esophageal, for adenocarcinoma, it's GERD and Barrett's. A lot of people who don't know that they have it. Diet, nutrition, and obesity are big things. Alcohol and tobacco are mostly associated, alcohol and tobacco are associated with everything, but mostly from an esophageal standpoint, mostly the squames. And then there are those, things you learn about in medical school, tylosis and familial squamous cell cancer, neither of which I've ever seen. And there's gastric cancer, H. pylori is the big one, tobacco, just like everything else, advanced stage, male gender, again, diet and obesity. And then from a genetic standpoint, you see gastric cancer is one of the ones you see with HNPCT, along with breast, endometrial, ovarian, colon. You can also see it in FAP, and then there's also a hereditary gastric cancer syndrome, which is CDH1. So that's family history-wise, so that's like in every family member. Clinical presentation. So patient can present with anything. So some people just present with a little bit of, I saw a person last week who just had a little bit of belly pain, and then lo and behold, they had gastric cancer. Esophageal patients can have dysphagia or dynaphagia. Often that comes out of the blue, so they're fine, and then all of a sudden they can't swallow a hot dog, and then they've got this big tumor. Some patients have iron deficiency anemia, weight loss. If they have an upper esophageal tumor, patients can have hoarseness, cough, things like that. And then I've seen a few people that just presented with specific adenopathy. So basically anything. The workup, so upper endoscopy, obviously everybody gets. PET-CT we use for esophageal cancer, mostly because it's more sensitive, particularly when you're trying to decide, you don't want to accidentally take out someone's esophagus when they have metastatic disease. So everyone should get staged everybody gets an upper endoscopy, that's how they get diagnosed, then they get a PET-CT, and then everybody gets an endoscopic ultrasound. And endoscopic ultrasound is what, you don't need that if you're metastatic, but otherwise endoscopic ultrasound is what directs the treatment. So if you have a T1 lesion, you can go straight to the operating room. If you have T2 or greater or any node positive, no matter what your T stage, you should be considered locally advanced and should get multidisciplinary treatment. There's a little bit of controversy over the T2, but most of those are bulky, and if you talk to thought leaders, most of them will say if you have a T2, you should just get neoadjuvant. Because the problem is if you don't, and then you take them to the operating room and they're node positive afterwards, it's a hell of a lot more difficult to treat them. So we have a guy who I have now who was a T1, surprisingly, on his EUS, and then he was a T3, M3 at the time of the resection, and so we're just way backpedaling. The other thing to know from an esophageal standpoint is if the tumor is at or above the carina, you should get a bronch. Most of those will be upper squames, and that's because you can get it. You want to see if you have a fistula before you start, so that you can act accordingly and stent if you need to. You don't want to accidentally discover you have a fistula. In terms of staging, I'll just go through quickly. So most of the patients we see are T3, so invading into the adventitia, and then the T4s are the bad ones that are sort of invading into other things. For nodal staging, it's just regional number of nodes mostly. About 50% of people we see have unresectable or metastatic disease from the get-go. That's about the same for gastric as well. About 50% of those patients will be unresectable or metastatic when you see them. Otherwise, you can see vast majority of people present stage 3. Survival-based stage, we kind of talked about. Metastatic disease is pretty minimal. If you have an early stage like a T1, they just go right to the OR. Most of those people, those are the ones you cure, but other than that, you pretty much don't. In terms of neoadjuvant treatment or non-operative treatment, I just wanted to run through some of the data behind what we do. So there are 2 RTOG trials that looked at radiation plus or minus chemo, 8501 and 9405. And you can see based on when these were done, so this one is with way more adeno, though it was 80 to 90% squames. They randomized 129 people. They also had a non-randomized cohort that also got chemoradiation, and they were looking at overall survival and patterns of failure. This is just a regimen, so the old 5-FU cisplatin that we don't use anymore. And if you look radiation plus chemo, you can see statistically significantly better median survival, whether it was in the randomized cohort or in the non-randomized cohort. And those who had chemo and RT had less persistent disease and less, not that much less, but a little bit less local regional recurrence. So basically, additional chemotherapy reduced first and overall treatment failures, as well as the incidence of metastatic disease as you would expect. So this kind of said, okay, you probably shouldn't do radiation by itself. This is the same, so mostly squames. They got cisplatin with radiation or just radiation alone, and this was looking at, does a higher dose of radiation help you or not? And what they saw was with high dose radiation versus moderate radiation, there wasn't really any different. So high dose radiation didn't improve. That's how we ended up at the 50-40 centigrade, which is what people get now. About that. In terms of neoadjuvant chemo by itself, as opposed to radiation, so the Intergroup 113 study is an older study where they randomized 440 patients with resectable squamous or adenocarcinoma to surgery alone or sandwich with chemo before and after, and then surgery in the middle. If you look, the things to look is that most of these were, again, squames, so there's only really about 16% that were adenocarcinomas, probably the biggest thing. And a lot of people, 3% got both cycles, 6% got no cycles of chemotherapy after. So they pretty much got the pre-chemo, but not so many people got the post-chemo. And the trial was negative, so it didn't matter whether you got surgery or surgery plus chemo, it was the same. So that does not argue for just doing chemo period for esophageal. Although, again, it was mostly squames. MRC-002 was 800 patients done in the UK with surgery alone or chemotherapy up front followed by surgery. So they didn't even try to do chemo out back. And their 2-year survival was much better if you got chemo plus surgery. Although the interesting thing about this is it wasn't done very well and some patients got radiation. And so it's hard to kind of tease out exactly what part of that was radiation contributing or not. And they had long-term follow-up data which again showed their 5-year survival was better in those who got chemotherapy and surgery. So basically, suffice it to say, if you have a locally advanced esophagus cancer, don't just do surgery by itself. Chemoradiation is the standard. They also looked at whether it made a difference if you were adeno or squam, and in their series it did not. There's some data emerging to say that maybe you don't need surgery if you get treated beforehand with squamous cell, but in this particular trial it didn't matter. So this is where there's a bit of a dichotomy. So in the UK, most people get preoperative chemo, and here in the US, everybody gets chemoradiation, and it's just a difference of opinion. The data is much more strong for doing chemoradiation. I had to do a debate against a guy from Sloan Kettering, and I was like slaughtered because I had to do the chemo side, which I was mean because he was more senior than me. But there's no, if you look at all, and I'll show you a randomized trial, like chemo has no leg to stand on, basically. So why do they only do chemo? I don't know. They just
They don't have their shortage radiation oncology.
They just don't really. It's just their thing that they do. So this is neoadjuvant chemoradiotherapy in the modern era. So there are 6 trials. I'm just going to talk about 2 of them. So before the VEGAS trial, which is the cross trial, which is the very bottom one, came out at ASCO now 3 years ago, I guess, it was a mess. So there were a couple of other trials, a couple of negative trials. It was all mixed between squams and adenos. But then so I'm going to talk about the CLGB trial and the cross trial. So if you look here at the number of patients, so all of them are, well, reasonably small. The cross is the biggest one by far. And if you look at 3-year survival just in aggregate, the CLGB study was positive. The caveat to that was it was very under-enrolled, and there was hardly any patients in it, but still there was a 5-year survival benefit. And cross trial was definitely, if you had chemoradiation therapy plus surgery, you did way better than if you had surgery alone. And then sort of discount the other ones. So 9781 was probably the first big one. So surgery alone versus pre-op chemoradiation with cisplatin. They wanted 500 patients. They only got 56 patients in 2 years because people were pretty wedded to, I'm going to give people radiation, I'm not just sending people, or I'm going to give people chemoradiation, I'm not just sending them to surgery. So that's why they had a hard time accruing. This is their backbone, which is the same old cis-5FU backbone. And then this is their data. Their 5-year progression-free survival is 28 versus 15%. And this is their survival curve. So it's tiny. It's a tiny trial, but they're definitely, in my mind, there's enough to say that we should change what we were doing. Cross trial, the reason they designed it that way, because there were 2, preoperative chemoradiation looks like it's better, stronger for adenocarcinoma, and they wanted to, and there was also concerns that it might increase postoperative mortality. So they wanted to do a bigger trial, because before that we just had all these little tiny trials. So you could be squam or adeno. You had to be, you could be T1, like I said, those people go right to the OR, and you couldn't be metastatic, and you could have like a super long tumor. So they do carbotaxol weekly, so it's AUC2 and 50 per meter squared, which is actually pretty easy to give. In terms of, went to the operating, there were patients that were node positive, were the same between groups, and adenocarcinoma squamous were the same between groups. Most everybody got all their chemo. The resection rate was way better than those who got chemo, and morbidity and mortality were almost identical. And you see here the 2-year survival was 67 versus 62%, and the median survival was 49 versus 26 months, so pretty significant. This is what we do now. So standard of care for locally advanced esophageal tumor would be carbotaxol weekly for 5 weeks, or when they get their 50/40 centigrade. That's anybody, like I said, who's greater than T1 and 0. There's these other 2 trials which I threw in here, just kind of highlight the fact that there's some suggestion that maybe we'll start treating squamous cell cancers differently, although we don't right now. So this was a phase 3 study that just looked at squamous cell cancers, and they looked at chemoradiation alone versus chemoradiation plus surgery, and they were just looking for equivalence. To say, do we even need to do surgery, because surgery is such a big deal for these people. It was kind of a funky design, and the chemo they used was this 5-FU etoposide cisplatin, so that was a little bit weird. But if you look, they had, at 3 years, their overall survival was statistically equivalent. So there's a numerical difference, but it was statistically equivalent. So they sort of said, well, maybe if you're squame, who do tend to respond better than adenos, perhaps maybe you don't need surgery. And that's their overall survival. And from local progression was also not, well, that was worse. Thought chemoradiation alone was equivalent to chemoradiation plus surgery, and said maybe surgery is not necessary for all patients. But if you ask anybody now, they'll say we don't have enough data, which I would agree with. I think we need more data, because I think they may be right. But if you look, this is 10-year follow-up data. If you look at the overall survival at 10 years, it's still pretty bad for both of them. So maybe you don't, but I don't think we really know. If you look at disease-specific 10-year survival, though, there's a 13% difference, which I would argue is clinically significant, if not statistically significant. But it was a small trial. This trial looked at the same kind of thing. So it had mostly squames that were randomized to chemo with cisplatin 5-FU radiation, and then they said, okay, if you respond, you're either going to keep getting chemo or you're going to get surgery. And they had, in the surgery arm, their median survival was 17.7 months, and the chemoradiation arm was 19.3 months, so not significantly different. Let's skip that. So they also said if you're responding, then maybe you shouldn't get surgery, which seems to happen in most of the squames. But again, the jury's still out. So as it stands now, everybody should just get resected. So squamous cell cancers, surgery improves local control, but may not necessarily improve overall survival. But that said, those patients should all go to surgery, because we're not even sure how to follow them. We don't know exactly what to do. And in adenos, definitely pre-op combined modality surgery is better than surgery alone. Let's skip this.
Does HPV status matter for the squam?
Interesting. I don't think there's data on that. We've checked it in some of the, for fun, in some of the really, really high cervical cancers, but there's no, because we've kind of said, okay, are those more head and neck since they're way up? But we haven't, and we've sort of tracked and said, okay, well, the HPV positives do tend to do better than not, but there's no straight data for that. So the other trial I wanted to talk about in terms of perioperative chemo is more for gastric cancers. So MAGIC is the big trial to know about, which enrolled either adenocarcinoma of the stomach, lower esophagus, or GE junction. So it was about 25% that had gastroesophageal, either GE junction or esophageal tumors. Again, this was done in the UK. Surgery alone versus ECF in the front, surgery and ECF in the back. And they were looking at overall survival and progression-free survival. And they were pretty evenly randomized. So interestingly, in perioperative chemo arm, as you would expect, the tumors were smaller because they'd had chemo and been shrunk by chemo, but there were no past CRs, and they had more T1, T2 disease. So they definitely had people that responded, and they also had an improvement in 5-year survival, which was statistically significant if you did perioperative chemo. So this applies more to gastrics in my mind. So it improves overall survival, improves progression-free survival in downstages tumors. So then the next thing, so locally advanced esophageal should get chemoradiation. Locally advanced gastric perioperative chemotherapy a la MAGIC is acceptable. There's actually no data for radiation in the neoadjuvant treatment of a true gastric cancer. So if it's, in the body or an antral, there's no, we do give them radiation, but there's no data for that. So for the boards, if you have a locally advanced gastric, they should get perioperative chemo, no radiation. So the next thing in talking about these tumors is what to do about all the biologics. So trastuzumab is obviously something we use in the metastatic setting. Where does it stand in the locally advanced setting? So there's a trial going on, which is still accruing. So they're looking at HER2 positive cancers and randomizing them to chemoradiation plus trastuzumab or chemoradiation alone, followed by surgery. And the trastuzumab arm would then get 1 year of kind of maintenance trastuzumab. So this will be interesting. A lot of us are waiting to hear, because sometimes you check her too. I don't usually check it until I know people are metastatic, but sometimes people come in and they're too positive, and people are like, well, what are we going to do with that? I'm like, nothing. And although I have had some people in the community that have added trastuzumab to radiation, but there's no data for that. So again, for the boards, Herceptin, as it stands right now, is only in the metastatic setting. So kind of moving on to metastatic patients. So when patients present and have metastatic disease, what to do. One thing I wanted to talk about in terms of managing people in clinic, less for the boards really, is what to do about managing people who have local symptoms. So there's, you can either do, I always said I was going to be one of those people that didn't have different formats of slides, but I just ran out of time. Like, forget it, I'll be one of those people now. So there are things you can do. You can either do palliative chemoradiation, which typically, depending on what you're going to do, I have on here you would do it just with Xeloda or infusional 5-FU. Depends on how robust your patient is. So if you see someone who walks into your clinic and has metastatic esophageal cancer and can't eat, the decision point is their systemic disease going to blow out of control before you can finish radiation, or can you get away with it? So it's sort of a judgment call. Obviously if someone's liver enzymes are up, if their liver's filling their belly, all sorts of other things, then probably the best thing to do is put in a feeding tube and treat them systemically. Otherwise, if they have minimally metastatic disease or very small volume disease and you're not thinking it's going to get out of control, what I would argue is you should palliate them with radiation first. Once an esophagus has been radiated, people don't recur in the esophagus. So you can kind of do it, they can eat, they'll be better for it because they'll do better with everything else, and then you can move on. Typically, the chemo you can use can either just be Xeloda or infusional 5-FU just to be sort of lighter. Although if people are pretty robust, you can do carbotaxone, you can tolerate that. And then once they finish, they would come back and do systemic therapy. The other thing you can do is do esophageal stents, which I hate. I don't put them in people, but I included it for completeness sake. They do work. They don't work well for GE junction lesions, because if you can imagine, you try to put something across the junction, then you just have a super highway of reflux. A lot of people say, well, you can put in a stent and then they can eat normally. People really can't eat normally. And they can migrate and they can bleed and people feel them and they're just a mess. So in metastatic patients that I've never put one in, but I hardly ever put them in. The other thing is in the neoadjuvant setting, you don't want to put one in because it makes the surgery a lot harder. So to be avoided, but may have some role. Esophageal dilatation is what we do, so I typically will send my patients to the surgeon to be dilated. GI can do it. The GI is hampered by the fact that people are just consciously sedated, so they can't be particularly rough with it. So the thoracic surgeons just do a better job for that reason. And also, they can also fix it if they mess it up, I guess. But the surgeons just can be more aggressive. So that's where I usually send my patients. And then the other thing is photodynamic therapy, which we don't use a lot, but it's something you can keep in mind. So basically patients have to get treated the day before with the photofrin, then they come in and go to the operating room and they get the light shone in there. The drawbacks to this are people have to be out of the sun for 6 weeks, like not even in the carport during the day. So it's very, especially in Buffalo where I'm from, it probably wouldn't make much difference. There's no sun up there. Here really you have to stay inside. So I've used it on a couple of people, like the patients I've used it on are somebody who didn't want any treatment at all but couldn't swallow and said, if you can get me to swallow, I will be much better. And so we did it, and he was like this little man who lived by himself and didn't care about coming out of the house. So we did it for him. I had another lady who actually had minimal metastatic disease but really had never been radiated but was progressing in her esophagus, and we did it for her, and she didn't care about not coming out of the house, and actually worked really well. So it's something to think of, but something we use regularly. So those are the three. Yeah, and then the other thing, obviously, if you need nutritional support, is to put in a feeding tube. I will say that 95% of our patients don't need a feeding tube. So I see sometimes people who come in consult, and they're like, oh, you have esophageal cancer, we'll put in a feeding tube and start. And then people are like, well, I don't use this thing. Why do I need it? You can get people through if you know what you're doing. So in terms of systemic therapy for metastatic disease, so is no universal standard. So what I usually tell patients is it's a good thing because there are a lot of different options, but it's a bad thing because there are a lot of different options. So I think most people kind of have their general way they do it. So there's the triplet regimens, which is the ECF and EOX. So I would say probably most of us don't use any epirubicin, generalizing a bit, but most of us don't use any epirubicin anymore. I'm not sure what it adds other than toxicity, to be completely honest. So I don't use it. I know Jafar Ajani doesn't believe in it either. So that's my litmus test. Then the DCF, which is a very aggressive regimen, but also has a lot of toxicity. So I don't use that a lot either. There's data for that in the first line. There's data for EOX in the first line. There's some data at MD Anderson, which I didn't include in here, for another triplet, which is Taxotere, oxaliplatin, Xeloda, which actually has a 60% response rate, and it's just an abstract form, but you can use that. So I think they can ask you a question on the boards about what you would use, other than what should you check before you give anybody chemo, which is you need to check for their HER2 status, either by IHC or by FISH. So we typically, if IHC is 0 or 1+, then they're done. If they're 2+, we FISH them to be sure that they're not FISH amplified. If they're 3+, you don't need to FISH. So the trial that sort of looked at ECF versus EOX, which is somewhat, I guess, esoteric now because we don't use it very much anymore, but with the REAL-2, so 1,000 patients, 2x2 factorial design, basically looking at equivalence of oxaliplatin to cisplatin and equivalence of Xeloda to 5-FU. So they included anybody, esophagus, GE junction, stomach, adeno. It was non-inferiority. These are the groups. So most patients had esophagus or GE junction, about 60 to 70%. Most of them were metastatic, and 90% of them are adenocarcinoma. So it's a little hard to generalize this to the squames. And it was non-inferior. So capecitabine was non-inferior to 5-FU, and cisplatin was non-inferior to oxaliplatin. And in terms of median survival, it was not designed to look for superiority, and they're all about the same, except for if you look at the EOX, 11.2 months versus the 9s for the rest of them, so maybe a little better, but again, it wasn't designed for that. And then median survivals were about the same, 6 to 7 months, which is about where. So the interesting thing with all the regimens for gastric cancer, they all bump up against 9 to 10 months for overall survival and 6 to 7 months for median progression-free survival. It doesn't matter what you use. And overall response rates are always about 50%. So it's nice, it's easy to remember. So I talked about capecitabine is equivalent to 5-FU, oxaliplatin is equivalent to cisplatin, and oxali are better tolerated, and then toward improved survival with EOX. DCF I'll just include because some people still do use this, and I still do think it has a little bit of a role. This was a study that Jafar Ajani did, 457 patients, Taxotere, cisplatin, 5-FU versus cisplatin, 5-FU, and they were looking at superiority. And these were just adenocarcinomas. So whether with regard to time to progression, so 5.6 versus 3.7 months, and also overall survival, there's that 9.2 months versus 8.6 months. The problem that I have with it is it has a lot of hematologic toxicity. It's hard to give, and it's hard on people, because they have to be, so you get Taxotere and cisplatin on day 1, and then you have a pump for 5 days. So you are on chemo for 5 days, then you feel crappy for 5 days, and then you have 5 days of feeling well, and then, it's time for more chemo. So that's why I don't use it. So you need 82%, so there's a lot of need for support. Cisplatin irinotecan is a much older regimen. Once you get beyond the first line, sort of the EOX and all the old stuff and the Herceptin trials, it all kind of falls apart. So there's very tiny trials looking at different things. There's no consensus second-line therapy for gastric cancer. There's not a lot of people actually go on to second line in this country, whether it's just for performance status reasons or because people don't know what to do. So theory is something I've used. I don't use it so much anymore, but you can do it. It's not that hard to give. So it's day 1, day 8, and it has a response rate of about 50%. and overall survival about 9 months. Again, this was in the first line setting. I wouldn't use this first line. Now, 5-FU platinum is standard for first line. So I would say for metastatic patients, check HER2. If they're HER2 overexpressed, they automatically go to some 5-FU-based, platinum-based regimen with Herceptin. If they're HER2 not overexpressed, I typically use the same regimen, FOLFOX, just without Herceptin. And then in the second line, you can either use a taxane or you can use irinotecan. There's not really any great data.
So most people use like Velox or trastuzumab, or do they use XP? Like, no one actually.
Nobody actually uses that. I guess the short answer is it's FDA approved for use with Xeloda cisplatin or 5-FU cisplatin, but that's not what we use.
So
practically everybody uses Oxali. So the big thing in gastric cancer, esophagogastric cancers, is targeted therapy. So VEGF is something that people have been looking at for a while, and VEGF expression is actually a negative prognostic factor in gastric cancer. So this is, I just included this for historical purposes. So this was the first trial. It's from Manish Shah out of Sloan Kettering, who looked at Avastin. So that was back in the day when people were doing Cis-Uri. So they did Cis-Uri Bev. Overall survival was 12.3 months, so thought to be much, much better than the 9 to 10. Response rates weren't that different. But then they had perforation and hemorrhage. So then, as you can imagine, you're treating with an intact primary in your esophagus or your stomach. So people were very concerned about that, whether or not it should even be looked at even further. So there were a ton of trials in here that I took out that are this plus Avastin and that plus Avastin and this plus Avastin, but none of that really matters. So this is the big one to know, is a 3 trial, which was done by Genentech, looking at locally advanced or metastatic gastric cancer randomized to capecitabine cisplatin plus placebo or plus bevacizumab given every 3 weeks. They were looking at overall survival, and then they had some other secondary endpoints. No previous chemotherapy. You could have had adjuvant chemotherapy. It had to be completed 6 months before randomization. No previous platinums or Bev or anything like that. In terms of patient characteristics, it's about the same. So this is the important thing to know about this. So the region, this was mostly done ex-US, almost exclusively. So Asia and Europe had most of the patients. I think the US literally had 10 patients. America, this was like South America, like Brazil. I mean, there was, we had it open and we couldn't get anybody on, and I can't remember why. Most people, and then most patients were metastatic. So if you look, most patients were stomach, not to worry about the intestinal type. And then actually a lot of people had an intact primary, so only 28% of people had their tumor removed. The things to look at here in terms of perforations, there really weren't, they had 2 perforations total, which is not awful. They did have, more bleeding. But you just have to know what you're doing. We had a trial here, and we only had a couple of bleeding events because we didn't include anybody who was bleeding and all sorts of other things. So this is for the entire study population. So everybody, whether they're Europe, Asia, whatever, 12.1 versus 10.1 months, and this was not statistically significant. So it was a negative study. Progression-free survival was the same, 6.7 versus 5.3 months. Again, not statistically significant. So it got a little interesting when you look at regional differences, and people are still talking about this. So if you look at Asia, not that much different. If you look at Europe, not that much different. But look at this, in the U.S., about 7 months versus 11 and a half months. The problem being, obviously, that was like 70 patients or whatever it was. There are differences that we're learning about in the type of gastric cancer that we get over here versus the type that they get outside of the U.S. So that's still being sort of looked at and worked out. But for all intents and purposes, this was a negative study. Overall survival was not improved. PFS was, is that right? Was not better. And there were geographic differences. So right now so if someone asks you, can you give Avastin in the first line, the answer is no. People are still looking at it to a certain extent, but the answer is no for the boards. I put in here as a placeholder, and I did have a whole bunch of slides, and that EGFR therapy is pretty much dead in gastric cancer. I should have put in real 3, which was chemo plus or minus Vectibix, which is a huge flop. It was totally negative, and actually looked like people did worse if they got an EGFR inhibitor. There were some studies before that suggested that maybe if it added anything, added a tiny bit of something, which is why they took it to REAL-3, but it's dead. There is no EGFR inhibition going to be used in gastric cancer. And then Herceptin we talked about. So one thing I wanted to talk about was, so the staining of looking at HER2 in gastric cancers is a little bit different than in breast cancers. So this is what they look at. So they look at a surgical specimen or a biopsy specimen, and there's membrane activity as opposed to sort of scattered throughout. So we talked about TOGA, or we didn't, we mentioned TOGA. So 5-FU capecitabine plus cisplatin, or 5-FU capecitabine plus cisplatin plus trastuzumab, IHC3 plus or FISH positive. The overall survival was 13.8 months versus 11.1 months. Progression-free survival was 6.7 months versus 5.5 months. And they looked at it based on whether you were FISH positive. They had some people that were FISH and IHC 0 and all sorts of different categories. So they said if you are FISH positive or IHC positive, and they took everybody else, it was the same. And they just had IHC 2 plus, FISH positive, or 3 plus. Sorry, I got that wrong. You did better, actually. So you did 16 months for median overall survival versus 11.8 months. So people who should get Herceptin should be IHC 2 plus and FISH positive, or IHC 3 plus. Anybody else shouldn't. It's not going to help them. And this is some response rate data, so better response rates with trastuzumab. Interesting, so Herceptin is used in the first line. Interesting, there was another trial, so they said, okay, well, what about if we do things like breast cancer? And if Herceptin works, lapatinib's got to work too. So they did this trial, which was the same population, randomized to Capox plus lapatinib or Capox alone. I don't have the data, but it was negative. So much for that idea. I think there are a couple other lapatinib trials, but this one is negative. Everybody's starting to look at HER2 in the second line. So there's actually no data for continuing Herceptin beyond the first line. Do we do it? Yes, we do. But there's no actual data to say that you should do it. So this study is the TITAN study, so looking at junction HER2 positive randomized to Taxol plus lapatinib versus Taxol alone. And this is accruing right now. So it'll be interesting because this again has lapatinib, which was negative in the first line, so who knows. Early results, 11 versus 14 months. So it's interesting, it's different. And then this is another, we have this study here, which is MM111, which is a bispecific antibody to ERB2 and ERB3. So it's kind of a cool drug, actually. So it's a randomized phase 2 second line. Patients, so they're doing two groups. They're doing the traditional HER2 group, which is 3 plus or 2 plus and FISH positive. Those patients all get Taxol, trastuzumab, and then they get plus or minus MM111. And they want to look at 2 plus and FISH negative, just to see what they see with their drug. And those patients will get Taxol plus or minus MM111. Those patients, as you can imagine, are harder to find because pretty much once you're FISH negative, you're just HER2 overexpression, you fall off the map. But they do have some patients enrolled. So we're enrolling that now here. So this is going to answer two questions. So it'll give us, does this antibody work, but it'll also give us some data about chemotrastuzumab in the second line as well. And then TDM1 is something that's sort of up and coming, but there's no, again, trying to follow in the footsteps of the breast people. There's no, I think there's a trial for that, but there's no data yet. So it's a second line TDM1 study, but I don't have any data on that. In terms of HER2 in general, in the first line, there's benefit for Herceptin, but logic was negative. In the second line, there was benefit with lapatinib, and then there's this MM111 drug, and then we're still not clear to do, if you're FISH positive, but your IHC, not 3 plus, that should be FISH, IHC 0 and 1 plus. We don't really know what to do with those because they didn't seem to benefit in the other trials.